This is a 56-year-old lady with several months history of shortness of breath. Her past medical history is as shown. A preoperative echocardiogram showed a subaortic membrane with aortic valve regurgitation, which was severe in nature. Patient had a preoperative CT scan, which showed normal vasculature. Due to the severity of her symptoms, it was decided to take her electively to the operating room and perform an aortic valve replacement and a subaortic membrane resection. The right groin vessels were exposed. Purse strings were applied. A wire was inserted into the femoral vein, where it was seen in the superior vena cava on bicaval view. A multistage cannula was inserted all the way up to the SVC, and it was connected to the tubing and secured in position. Next, a wire was inserted into the femoral artery, which was seen in the descending aorta, and a hybrid cannula was inserted. Next, the second intercostal space was entered. The mammary vessels were spared. A CO2 line was inserted along with a soft tissue retractor. The pericardial fat was removed and the pericardium was incised. To further improve exposure, pericardial stay stitches were applied to the anterior and posterior pericardium. These stitches were then exteriorized using a Carter-Thompson device. Next, space was created between the aorta and the PA to allow adequate placement of an aortic clamp. A trial of clamping was done to make sure both the blades were in adequate position, and a spot for a cardioplegia cannula was marked. Cardioplegia cannula was inserted, and a cross clamp was then subsequently performed. The aorta was carefully incised and stay stitches were applied. Adequate view of the aortic valve was seen and the leaflets were excised in the usual manner. Next, the subaortic membrane was identified deep in the LVOT and it was carefully peeled off its surrounding structures. Next, the aortic valve was replaced using a sutureless, commercially available rapid deployment valve. The aortotomy was subsequently closed in the standard fashion. A ventricular pacer wire was inserted before the cross clamp was removed. The aortic root vent and the LV vent were removed and secured with a core knot. Next, a multi-level nerve block was performed in order to achieve adequate postoperative pain control. The groin vessels were repaired and the chest was closed in multiple layers. The TEE showed an adequately functioning prosthetic valve and an absence of subaortic membrane. The specimen is shown here. The patient did remarkably well. She was extubated the same night and she was discharged home on postoperative day 5. Thank you.